The esophagus is a muscular transport tube extending from the pharyngo-esophageal junction at the sixth cervical vertebra down to the gastroesophageal junction. Most of the gastrointestinal tract is wrapped in a protective serosa. This cross-section shows that the esophagus is missing its outermost layer. Disease progression moves rapidly. Tumors originating in the mucosa can expand through the submucosa and invade the thoracic cavity without meeting significant structural resistance. Effectively managing esophageal trauma and oncology requires a top-down mapping of three specific anatomical constrictions, as these points dictate exactly where pathology will occur. The esophagus is a spatially complex surgical environment where precise anatomical coordinates govern patient survival. The descent begins 15 centimeters from the upper incisors at the level of C6. This is the first anatomical constriction, and with a diameter of only 14 millimeters, it is the narrowest point of the entire GI tract. This bottleneck forms the upper esophageal sphincter. It acts as both an anatomical and physiological barrier, constructed from the oblique and horizontal fibers of the inferior constrictor muscle. This structural diagram highlights a specific flaw called Killian's dehiscence, a triangular gap between the thyropharyngeus and cricopharyngeus fibers. Under high pressure, the mucosa can herniate through this weak point to form a Zenker's diverticulum. Because of this 14 millimeter limit, C6 is the most common site for foreign body impaction and iatrogenic perforation during endoscopic procedures. This geometric visualization illustrates identifying a swallowed coin on an X-ray. An esophageal coin sits in the coronal plane, showing its full face on an AP view. In the trachea, it's forced into the sagittal plane, showing its edge. While many smooth objects can be observed if they pass C6, a swallowed button battery is an emergency. It must be removed endoscopically regardless of its location to prevent rapid corrosive perforation of the esophageal wall. This rigid muscular funnel at C6 creates a mechanical bottleneck that demands immediate geometric and structural assessment. At 25 centimeters from the incisors, we reach the second constriction, where the aortic arch and the left main bronchus cross the esophagus. In this section, the submucosa facilitates rapid lymphatic flow upward and downward. Cancer cells travel far from the primary tumor, depositing skip metastases. To account for this, surgeons require a 10-centimeter proximal resection margin to ensure complete clearance. This mid-thoracic region is also the primary site for congenital tracheoesophageal fistulas, or TEFs, where the esophagus and trachea fail to separate during development. This schematic identifies type C, the most common variant. It features a blind proximal esophageal pouch and a distal segment that branches directly off the trachea, allowing air to flood the stomach and secretions to enter the lungs. Surgical triage for these infants depends on the Waterston criteria. Surgeons assess if the child is a candidate for immediate repair based on a birth weight over 2.5 kilograms and the absence of pneumonia. Pathologies in the mid-esophagus, whether they are metastatic clusters or congenital connections to the airway, routinely bypass local boundaries and threaten the entire thoracic cavity. When corrosive agents are ingested, the specific chemical mechanism determines the depth of tissue trauma. Alkalis cause saponification, liquefying tissue and allowing chemicals to penetrate deep. Conversely, acids cause coagulation necrosis, forming a superficial crust that limits deep damage. Because the necrotic wall becomes structurally unstable, a blind nasogastric tube must never be inserted, as it carries a high risk of puncturing the esophagus. Skilled endoscopy must be performed within 48 hours to map the injury before the tissue becomes too fragile to tolerate the procedure. The Zargar classification grades the damage from Grade 1 edema to Grade 2 ulceration, Grade 3 transmural necrosis, and finally Grade 4 perforation. Managing chemical trauma is a race against time to visually map the necrosis depth before the structural integrity of the esophagus collapses. We reach the final constriction at the T10 vertebral level, 40 centimeters from the incisors, where the esophagus passes through the diaphragm. The lower esophageal sphincter is a physiological high-pressure zone, maintaining a resting pressure of 8 to 25 millimeters of mercury. Frequent relaxation leads to GERD, while a complete failure to relax creates a bottleneck seen in achalasia cardia. The vascular anatomy of this lower third is distinct, receiving blood from the left gastric artery and draining into the left gastric vein. This creates a direct connection to the portal circulation of the liver. In cases of portal hypertension, the liver blockage forces blood backward through the left gastric vein. This pressure balloons the delicate submucosal veins, creating life-threatening esophageal varices. The lower esophageal sphincter serves as a high-stakes junction, where hepatic pressures and gastric acids constantly assault the esophageal lumen. Successful clinical intervention is entirely dependent on recognizing these specific spatial coordinates. We must account for the mechanical bottleneck at C6, the diffuse lymphatic spread within the mid-thorax, and the complex pressure gradients at T10. These systems dictate whether a patient requires simple observation, an emergency endoscopic retrieval, or a radical surgical resection. Masterful management of the esophagus requires a deeply intuitive, three-dimensional mapping of its unique structural vulnerabilities.